Please allow me to now introduce our speaker for today's session. Dr. Austin Larson, Assistant Professor, Section of Genetics and Metabolism with Children's Hospital, Colorado. Thank you all again for joining. Let's begin.
So thank you, Sabrina. I'm really happy to be here again and talking with you all about genetic testing and genetic care for patients. So this talk this month is building on the talk that I gave last month, which was about the evolution of genetic testing and how testing has improved and gotten cheaper and gotten more accessible over the last several years, and what the implications of that are for genetics practice. So I'm going to be a lot more detailed this month with what exactly the strategies are for testing children with developmental delay based on recent advances. And what I'm going to talk about is to show you the current guidelines that are in place and to talk about how those guidelines are a bit out of date at this point and how they don't actually reflect practice within the genetics clinic anymore. So we will also then get into a discussion of potentially cost effectiveness of a couple of different strategies. So I have received compensation for giving lectures on this topic for Illumina and Medscape. I also participated in a number of industry-sponsored clinical trials. I will not be talking about any of those companies or topics today. So in the genetics clinic, developmental delay is by far the most common indication for both seeing a geneticist and for getting genetic testing. I would estimate that at least 75% of the patients that I see have developmental delay as at least a component of their clinical picture, if not the primary symptom that they have. And so because of that, this is by far the highest yield topic to focus on in terms of how to approach genetic testing in a thoughtful way. And it's also a place where pediatricians in the community are almost always the first folks to identify that a patient has developmental delay. And they're also the first folks that have an opportunity to intervene, both in terms of providing or referring for developmental services, but also in terms of a diagnostic evaluation for those children. So the most recent publication on this topic from the American Academy of Pediatrics was published in 2014. The lead author on that publication was Dr. Moschler. This is a really nice paper, and I like it a lot. It has a really thoughtful discussion of this topic, but it's also 6 years old now, which is getting pretty old in the world of genetics. One of the things that I really like that they touch on is the reasoning behind why one would do genetic testing for a patient with developmental delay. And they provide 9 reasons that one might want to pursue that. So the clarification of diagnosis is the first reason. So it can be very helpful to resolve uncertainty for families to give them a specific diagnosis. The ability to provide prognosis and expected outcomes is another reason to pursue genetic testing. A third reason would be the ability to counsel families on their recurrence risk. A fourth reason is that for some causes of developmental delay, there are actually disease-specific therapies that can be given, whether that's a medication or a diet or a vitamin or supplement or some other type of therapy that is intended to change the course of the disease and not just treat symptoms. Another reason to pursue genetic testing is to avoid unnecessary or redundant diagnostic tests. And I would include in that statement that we can avoid expensive and invasive tests as well. So things like sedation for MRI or sedation for endoscopy or echocardiogram, or any number of other tests that may happen for children that might not need to happen if we knew the exact genetic cause of their developmental delay and associated features. Families can be given much more specific information if they have a genetic diagnosis as opposed to the more general diagnosis of developmental delay or intellectual disability. Families can be in touch with other families and condition-specific support groups. So a lot of times now that takes the form of a Facebook group, but in other cases, there are very well-funded and well-organized family groups for specific genetic diagnoses. When patients have a specific diagnosis, even if there's not a medication that is labeled for that specific diagnosis, it's possible that there could be clinical trials or just natural history research that families could participate in. And one thing that I've found is that a significant number of families derive a lot of meaning and a lot of comfort from having the ability to participate in research and potentially help others in the future that have the same diagnosis as their child. And lastly, there's the opportunity for co-management of appropriate patients in the context of a medical home to ensure the best health, social, and healthcare services outcomes for the child and family. So having a genetic diagnosis as the organizing principle behind care can often lead to better coordinated care and better services for a child. So diving into that paper a little bit, and again, this was from 2014, they talk about how chromosomal microarray should be considered a first-tier diagnostic test in all children with developmental delay for whom the causal diagnosis is not known. They go on to state that karyotyping or chromosome analysis has been an accepted part of the diagnostic evaluation for 35 years, and that really has been supplanted by the microarray. And what I'm going to talk about today is sort of the next step of that evolution of genetic testing. But just to give you a little bit more background for those folks that weren't on the webinar last month, chromosome analysis or karyotyping is the act of taking a blood sample, treating the cells so that they are all at a certain point in cell replication, and then looking at those cells under a microscope and just visually assessing what the appearance of the chromosomes are and the number of chromosomes are. And as you can imagine, given that that's an individual looking under a microscope, that's a pretty low resolution test. So you're looking for only very large scale changes. The microarray is really an evolution of that idea, so that rather than looking with your eyes at the chromosomes, you are looking with a million or more DNA probes and an extremely high resolution camera that can tell you whether tiny little pieces of DNA are missing or duplicated. So as opposed to very large scale changes, we can now look at small scale changes. But what the chromosomal microarray can't do is look at changes that are within the gene. So the chromosomal microarray can tell you about the presence or absence of a gene, but it can't tell you if there's a sequence difference within the gene. So that's still too high of a resolution for the chromosomal microarray. And one of the really common questions that I get when I'm on call for our genetic service is a call from a provider who would say, my patient has developmental delay, they've had a chromosomal microarray, I'm now wondering about Noonan syndrome or Rett syndrome or some other very specific diagnosis that they're wondering about and wondering whether the chromosomal microarray was an adequate test for that. And the answer usually is no, because the chromosomal microarray is really just limited to those changes, those genetic changes that are on the scale of an entire gene or larger. And most of the named syndromes that we talk about are sequence changes within a gene. So in addition to that discussion of chromosomal microarray, the AAP guidelines also talk about screening for inborn errors of metabolism. And they state that since the initial guidelines in 2006, and remember this is now 2014, there have been additional reports about metabolic testing for causes of intellectual disability, and that the percentage of patients with identifiable metabolic disorders as a cause of intellectual disability ranges from 1 to 5%. Now, that 1 to 5% number, those papers, those publications, bridge the onset of expanded newborn screening. So expanded newborn screening came about in most states in 2006, and in Colorado came about in 2006, of the dramatic expansion of newborn screening from a few targeted tests to a much broader assessment of the metabolism of the patient, and a significant increase in the number of different metabolic disorders that we were looking for. And as a result, my impression of the diagnostic yield of metabolic testing for patients with intellectual disability is that it has probably gone down in the era when we are identifying a significant number of those patients at birth. Now, it's important to note that we don't test for every single metabolic disorder on newborn screening. We test for about 50 different metabolic disorders. So there are still gaps in that, but that also means that as a general rule, if you are applying this testing to the entire population of individuals with developmental delay, a significant number of the folks with developmental delay have now been identified at birth, or who would go on to have developmental delay have now been identified at birth, and they have a definitive diagnosis prior to ever presenting with developmental concerns to their pediatrician. They do list the metabolic screening tests that they recommend, and that includes amino acids in the blood, homocysteine, which is kind of a special amino acid that can't be picked up with the normal assay for all the other amino acids, the acylcarnitine profile, and then organic acids in the urine, creatine metabolites in the urine, purines and pyrimidines, mucopolysaccharides, and oligosaccharides in the urine. And that's a pretty good broad evaluation for a variety of different metabolic disorders. And in a later slide, I'll talk about how much that costs, and we'll sort of rank that with the cost effectiveness of other tests that we have available now. So this is the algorithm from the AAP. So a provider would start with a history, and that would include a medical history, family history, a physical exam, and neurologic exam. If on the basis of that clinical evaluation, there's a specific diagnosis that's suspected, then confirmatory testing can be obtained for that specific diagnosis. And once that diagnosis is established, the family can receive care for that diagnosis. However, as is much more common, there will not be a specific etiologic diagnosis that is suspected on the basis of that initial clinical evaluation. And then we're into that microarray that we talked about. They also recommend Fragile X testing as a first-line test. And the importance of having Fragile X testing here is that Fragile X testing is something called a trinucleotide repeat expansion disorder. So what that means is that it's a different genetic mechanism from most other genetic conditions. And as of right now, but probably not in the relatively near future, as of right now, that requires targeted testing to look for that specific condition, because it won't be picked up on our broader tests like microarray or some of the other broad tests that we'll talk about later. They say that a provider could consider metabolic testing in this very first round of testing. Again, if a diagnosis is established, you would provide care for that specific diagnosis. If a diagnosis is not established, then you could move into, again, the metabolic testing. You could consider brain imaging like an MRI, or gene panels. So what I'm going to talk about today really is the relative merits of this gene panel and just how much better these gene panels have gotten since this publication. And that really leads me to believe that these gene panels should be the first line test, and these other things should really fall behind that in priority. So the AAP is not the only entity that has come up with a similar algorithm. So the American Academy of Neurology has also endorsed an algorithm that actually looks pretty similar. Not surprisingly, it has a few more neurology-specific things that are recommended for children with developmental delay. Those are things like considering EEG testing. They also mention getting formal developmental testing, vision testing, and hearing testing very early in the diagnostic process, which I like. I appreciate that they recommend those things. They also recommend specifically a 3-generation family history, so a little bit more of a detailed family history, and going back to review the newborn screening labs. For all patients, they again recommend the microarray as the first-line test. They specifically call out Fragile X testing again, as well as MECP2 testing, which some of you may know is the genetic cause of Rett syndrome. They also mention that a head MRI is a reasonable test to pursue in the evaluation of developmental delay. And then they have a somewhat more extensive set of metabolic tests that can be considered in patients with developmental delay. But on balance, this is a relatively similar approach to that is published by the AAP. So let's talk a little bit about what's changed since those recommendations came out. So this is a paper that was published actually now in 2016. So this is a 4-year-old paper, but it touches on a couple of really nice topics. So one topic is this topic of the diagnostic yield for genetic testing or etiological testing for individuals with intellectual disability or developmental delay. And you can see that it was very flat from 1970 to 1985. So that is really just when chromosome analysis was the only thing that was available. There's a bump up as we started to get a few metabolic tests that we could do. We also started to be able to do a few targeted genetic tests and Fragile X testing, but then there's another plateau here throughout the 90s into the early 2000s. But then starting in about 2005, you can see this inflection point with this dramatic upswing in the diagnostic yield of genetic testing. And really what this is initially this is the onset of microarray, and then as we get into the 2010, 2015 era, these are broad gene panels that can actually sequence genes. And the ability to do that on an untargeted rather than a targeted basis has made the yield of genetic testing many multiples of what it once was. And I should say that this diagnostic yield of 60 or 70%, that is pretty specific to moderate to severe intellectual disability, as they state here. So it may not surprise people to hear that as the severity of developmental delay gets worse, the yield of testing also goes up commensurately. So individuals with borderline developmental delay or mild developmental delay have a much lower yield for genetic testing. Another one of the points that they make in this paper is that there's significant overlap between different neurodevelopmental disorders. So the genetic causes of autism have a lot of overlap with the causes of epilepsy, which have a lot of overlap with the causes of intellectual disability, and actually have a lot of overlap with the causes of schizophrenia. So there is, from my point of view as a geneticist, I don't derive a lot of value in terms of determining what testing I'm going to obtain. I don't derive a lot of value from having a very specific developmental profile, such as knowing that the gross motor delay is out of proportion to the speech delay, or knowing that that the child has epilepsy as opposed to not having epilepsy. those things don't really change the way that I approach diagnostic testing, given that our testing is now so broad. So I want to move into the question of whether the Fragile X and microarray tests really should still be the first-line test in the evaluation of a patient with developmental delay. So this was a paper that came out last year. This was published by the group at Children's National in Washington, D.C., and they looked back at 288 patients from their genetics clinic, and they looked at the diagnostic yield of that chromosomal microarray and of Fragile X testing. And there was a somewhat smaller number that underwent Fragile X testing. So there were 155 patients, whereas 288 had chromosomal microarray. And what they found was that the diagnostic yield of Fragile X was quite low. So it was 2 diagnoses out of 155 patients, or 1.5% of the Fragile X tests that were sent. Now, one thing I'll draw your attention to is that the yield of testing for individuals with autism was about 1/3 of the yield for those with intellectual disability but without autism. And that pattern has been shown again and again in different studies that are looking at the yield of testing in the setting of neurodevelopmental disorders, is that the yield is significantly lower in the setting of autism as opposed to intellectual disability without autism. And often it comes out to be about 1/3 of the yield. Sometimes it's lower than that, 1/4 or 1/5. So this pattern of seeing that the yield of Fragile X testing was quite low led this group to title their paper, "Do the Data Really Support Ordering Fragile X Testing as a First-Tier Test Without Clinical Features of Fragile X?" And the conclusion that they come to is that the answer is no, that that's probably not indicated. They went back and looked at those 2 individuals that were diagnosed, and they found that they had very characteristic both family history and medical history and exam features that were suggestive of Fragile X. This has been looked at in a couple other studies in the last year as well. This paper published in Neurology, or actually this abstract published in Neurology last year, had a bit of a different ascertainment. So rather than ascertaining from the point of view of a genetics clinic at a tertiary care center, they are actually ascertaining from the point of view of a genetic testing lab. So because of that, this is a broader ascertainment, and it's not surprising that the yield of genetic testing is lower with that broader ascertainment. So what they found was that only 3 out of 523 Fragile X test results were positive, so that was 0.6%. But across the board, they had a yield of about 1/3 of what we saw from the study that ascertained from the genetics clinic. So this may be a more accurate representation of what the yield of this testing is kind of out in the community that includes patients that don't ever make it into genetics clinic. So that's quite low. And I think most people would agree that yield probably does not support making that a first-line test. They found the yield of chromosomal microarray as opposed to 15 to 30%. They found that the yield of chromosomal microarray was 5%. And they then added on the yield of this autism and intellectual disability panel, which is a very large gene panel. You could almost call it a whole exome sequence. And if you remember from my discussion last month, we've really taken this leap in terms of sequencing from needing to just look at individual genes when we spelled out the sequence of the gene, to then being able to do panels of genes, say a dozen or 20 or 50 or 100 genes, to then moving to the paradigm where we just look at all the genes at the highest level of resolution. So that's 20,000 genes. If you look at all of them, there are about 7,000 genes that have been associated with genetic disorders. So any panel that is getting into the thousands of genes is something that I would consider sort of a whole exome equivalent. But in doing that very broad sequencing test, they found that the yield of testing was 10%. One last look at the yield of Fragile X testing. This was published by a group in Canada. And this was just a group of clinicians and their associated lab that had noticed that since those recommendations came out in the around 2010, or I believe it was 2006, that it was recommended that Fragile X become a first-line test in the evaluation of developmental delay. What they found was that there had been no increase in the number of Fragile X diagnoses. However, there had been a significant increase in the number of tests that were being sent. So what that told them was that the clinical assessment was actually a pretty good tool for identifying the diagnosis of Fragile X. And again, they found this yield of somewhere in the neighborhood of 1% or less for the Fragile X tests that were sent in the era of that being a first-line test for developmental delay. And I've included a picture here of a patient with Fragile X to make the point that there are some characteristic physical features of Fragile X that many pediatricians and developmental pediatricians and geneticists probably would be able to identify. In addition to that, there's often a characteristic family history with a mother that might have infertility. She might have a male relative with developmental delay, or there might be multiple affected male siblings with developmental delay. There can also be movement disorders in the grandparents or the older individuals in the family. So there are a number of clues that might lead you to that diagnosis, and that also means, again, that the clinical ascertainment appears to have been pretty good. So retrospectively, after a decade of having Fragile X as a screening test done for all patients, it appears that we didn't actually increase the number of patients with Fragile X that we were picking up, at least in these couple of studies. So let's move on to now the current era of testing that we have available. And as I mentioned, that's the whole exome sequence, or things that I would consider the whole exome equivalent, like a panel with thousands of genes related to neurodevelopmental disorders or developmental delay. And this is a paper that just came out in November of 2019, so this is just 2 or 3 months old. And this is a systematic review that looked at all of the papers that had published on the yield of whole exome sequencing in the setting of neurodevelopmental disorders. And this figure here is what's called a forest plot. So that's a way to aggregate the data that we had from these individual studies and to come up with a number as to what we expect the developmental, or what we expect the yield of genetic testing to be in the setting of developmental delay. So looking at these few dozen studies, they came to the conclusion, first of all, this looked at over 3,000 patients. They came to the conclusion that the expected diagnostic yield, while it varies quite a bit depending on the ascertainment of patients, overall you could expect the yield to be 36% of testing. And so that is considerably higher than the yield of metabolic testing, which I mentioned 1 to 5% has been published. I again favor the low end of that range, so more like 1%. It looks like the yield of Fragile X testing is probably 1%. And the yield of chromosomal microarray, again, varies based on the diagnosis, based on the ascertainment, but probably centers around 10% diagnostic yield. So this is dramatically higher than any of those tests. And importantly, I'll mention that this yield is the yield only for sequence variants, and they're not including the yield here for copy number variants. So one of the big changes that has happened in genetic testing in the last year or two is that labs have developed the ability to replicate the genetic the sensitivity for the genetic changes that were found on microarray, those copy number variants, labs are now able to replicate that with the sequencing test. So that's a big leap forward. And so we can actually add to this number, this 36%, we can actually add another 10% of microarray tests that we would, of the yield of microarray that we now would expect to find with the current generation of whole exome sequencing. So I would put this number more at like 46%. So because of that, this group that just published a couple months ago recommends an updated algorithm. So for patients with intellectual disability or autism, the first line test that they recommend is exome sequencing. And they state explicitly here that the goal would be for that exome sequencing to have copy number variant analysis, so that the exome sequencing could replicate the microarray in addition to getting all of the sequence data as well. Assuming you've done that, you don't need to do the microarray. And that's really the only step. This is actually a very short algorithm. If you've done the exome sequencing and you find a diagnosis, then you provide appropriate care based on that diagnosis. If you don't find a diagnosis and you are unfortunately using a lab that can't do this copy number variant analysis, you might need to then do a microarray as a second tier test. If you still don't have a diagnosis, then you might want to get a clinical assessment from an expert, someone that might be able to knowledgeably comment, oh, I actually do suspect Fragile X in this specific scenario, and it may be that Fragile X testing is appropriate based on the specific clinical features that I see. But if at the end of the day you still don't have a diagnosis, you can revisit this exome, and what we find is that the yield increases by about 10% if you just reanalyze the exact same data after 1 to 3 years. So there are still diagnoses to be found in that same data just by taking another look at it a year or two later. So their conclusion was that exome sequencing consistently outperforms chromosomal microarray, and they propose a diagnostic algorithm with exome sequencing at the beginning of the evaluation. I want to then tackle the topic of metabolic testing. So metabolic testing is a set of tests that you can do, often on blood and urine, sometimes on CSF as well, looking for many of the same things that are diagnosed on newborn screen, but also some other things that are not currently on newborn screening. Now, we can take that all the way to the extreme of what does this look like in a country that doesn't do newborn screening? And interestingly, in France, they do not do newborn screening for any metabolic disorder other than PKU. So this is a publication from last year about the yield of metabolic testing. And this is a slightly different scenario. This is in the neonatal ICU and not in the setting of developmental delay. But I'll tell you why I think that this is instructive. So for one thing, they made 4 diagnoses out of a total number of, I believe, 141 patients. So of those 4 diagnoses, all 4 of them would have been picked up by Colorado Newborn Screen. So they were all diagnoses that we do test for and have relatively good sensitivity for. The point that I really want to draw your attention to is the false positive rate of this metabolic testing. So the true positives, depending on the test, were right around 4%. The false positives often were 10 times that, like 60%, 70% for urine organic acids. So that's really my main concern about metabolic testing, is that the false positive rate is extremely high relative to the true positive rate. Now, that said, it's very important to keep these metabolic diagnoses in mind, because in some specific clinical scenarios, it's really critical to make that diagnosis. So, for example, an otherwise healthy 3-year-old boy who has 3 days of vomiting and then subsequently develops altered mental status, it would be really important to check an ammonia for that child to evaluate for the possibility of urea cycle disorders. So I'm not saying that metabolic testing has no role. What I am saying is that metabolic testing really should be obtained, in my opinion, in the setting of a specific concern for a metabolic disorder and not as part of the general testing for a patient with developmental delay. The other point that I'll make is that the broad sequencing test, that whole exome sequencing, really has pretty good sensitivity for metabolic disorders, and it has the ability to diagnose metabolic disorders that we can't identify by testing metabolites. So given that data that I've presented about chromosomal microarray and exome sequencing and Fragile X and metabolic testing, I want to do a thought exercise here. So let's say that you take a population of 100 patients with moderate developmental delay. That Fragile X testing costs about $250 per test. I think the yield of that is probably going to be more like 1%, but let's say it's 2%. That would then put us at $12,500 per diagnosis. The metabolic testing that I outlined, the costs can be a little bit more variable on that, and it really depends on which specific test that you do. But I would ballpark the average metabolic evaluation for a child with developmental delay. I would ballpark the cost at about $1,500. So let's again be generous and say that we have a 2% diagnostic yield there. At $1,500 per evaluation, that would be $75,000 per true diagnosis. The chromosomal microarray with a 10% yield and $1,000 per test, that would put us at $10,000 per diagnosis. And the exome sequencing, with current exome sequencing, we can take that number of 36%, we can add to that the 10% from the chromosomal microarray, and say that we have a yield of around 46%. That then at $2,000 per test would put us at a cost of $4,300 per diagnosis. So even though the exome sequencing is the most expensive test out of the four, it's by far the most cost effective, in my opinion. And that's why this is currently my practice. So I make exome sequencing or an exome equivalent test the first line test in my evaluation of patients with developmental delay. Now, I want to emphasize that you can't just set it and forget it. You can't just obtain a whole exome sequence and ignore all of the other information that you have about the patient. So it's still really important to consider what the role of other tests might be. Whole exome sequencing currently doesn't assess for nucleotide repeat expansions. So if you have a specific clinical suspicion for Fragile X, it's really important to send that targeted test. The tests that we get have variable sensitivity for mitochondrial disease, so we don't have time to go into what the characteristics of patients with mitochondrial disease or mosaicism or epigenetic disease. We don't have time to go into the characteristics of those patients today, but there is absolutely still a role for expertise and clinical judgment in assessing what the likelihood of the presence of those disorders are and whether additional testing beyond that untargeted test is appropriate. I will mention chromosome analysis. So once or twice a year, I do see a patient who has had all of the other testing we talked about, it's negative, and we go all the way back around to that initial test that we've had available for 40 years, and we find that they have a balanced chromosomal translocation as the cause of their developmental delay. Now, that's not justification for making that chromosome analysis a first-line test, because it still has quite low yield. It's, the yield is maybe somewhere around 1%, but it's also, I mentioned this just to say that we can't forget about these other tests, even though we have such high yield with that exome sequencing or exome equivalent. It's also really important to consider non-genetic etiologies of developmental delay. Could this be a child with a brain tumor or an infectious or hormonal or autoimmune cause of neurologic symptoms? So it's critical to keep those things in mind. And lastly, the genetic testing performs best when we have pretty detailed information about the patient. So one of the skills of clinical genetics now in the current era is knowing how to get enough information to get a really good interpretation of that broad genetic testing, but not overdoing the phenotyping of the patient to the point where you're delaying that genetic testing to a counterproductive degree. So practically speaking, I know that I've presented this data and I've talked about why, in my opinion, a first-line test of exome sequencing or exome equivalent is appropriate for patients with developmental delay. I also recognize that most providers outside of the genetics clinic don't currently have the resources to order exome sequencing. So I'm not asking you to go out and compile a lot of resources to be able to do that. And I'm also not saying that chromosomal microarray and Fragile X, if you have the ability to do those tests, I'm not saying that that's not a reasonable place to start. But what I am asking is that you please keep an open mind about the fact that this broad genetic testing really clearly, in my mind, has characteristics that make it a better first-line test in the setting of developmental delay, and that you keep that in mind. And it's just a matter of time, whether it's 1 or 2 or 3 years from now. It's really just a matter of time before that does become the first-line test, not just in the genetics clinic, but outside of the genetics clinic as well. So keep your eyes open, keep your ears open, and bear in mind that that change is coming in the not too distant future. So thank you all for listening, and we have 15 minutes left. If anyone wants to talk about any cases, if they want to ask about any aspects of this presentation, or if anyone has any comments that they want to share with the other folks on the call.
I do have one question that came in from one of our participants here. Actually, two-part question. The first is, many clinicians will be worried about doing the informed consent before genetic testing. Do you recommend using an educational tool that can help families understand what genetic testing means and including this in the medical record?
So that's a fantastic question. So that's a topic that I didn't touch on today, which is the informed consent for broad genetic testing. And there are a couple of answers to that question. So one is that a number of labs provide the informed consent and a discussion with the genetic counselor as part of the package of services that they make available to primary care physicians. So that's one answer. A second answer is that a number of labs also have videos that can be provided for patients to watch, and patients can understand the intricacies of the testing in a way that will allow them to make a decision about whether they do consent to the testing or not. I would say this is probably a good point for me to just give you a few-minute blurb on what informed consent entails for genetic testing. So the biggest piece of informed consent is patients opting in or opting out of secondary diagnoses. So secondary diagnoses are things that the lab finds that are not related to the reason for testing. So if exome sequencing is obtained for the indication of developmental delay, and you find a diagnosis of a cancer predisposition syndrome, that is a secondary diagnosis. And we want people to have made the decision consciously about whether they get that information or not. All labs that I'm aware of offer the option of opting in or opting out of having secondary diagnoses included in a test report. And just to give you a sense of the scale of that, most studies show that it's 1 to 2% of the time there's a secondary diagnosis on a whole exome sequence test. A second thing that families should know about is that if testing is sent on multiple family members, so I didn't talk about this either, but the exome testing can be done as a trio, and it has a better diagnostic yield if samples from both biological parents and the child are sent together. And if you send samples from multiple individuals, it's very easy to know whether those individuals are biologically related or not. So there's the possibility in the course of this testing to reveal to a family that the father is not the biological father of the child, and the mother is not the biological mother of the child. So that's something that families should be aware of. Lastly, most of the genetic testing labs that I'm aware of participate in research in one way or another, and they give families the opportunity to opt in or opt out of having their genetic data included in research. The final piece of the informed consent is that I talk with families about the fact that the genetic testing results are not always black and white. There is sometimes a clearly diagnostic finding. There's sometimes a completely negative test report, but there's also a significant number of times that there is a genetic variant of interest that is nevertheless has some degree of uncertainty associated with it, such that it can't be considered a definitive diagnosis in and of itself. And that despite doing this really great genetic testing that we now have access to, families may still have some residual uncertainty after getting a genetic result. So I try to make sure that I touch on those topics with a family. There are a number of resources available. So this webinar was organized by the Mountain States Regional Genetics Consortium, and I would recommend checking out their website. They do have some specific resources to help you with consent for genetic testing on the website there.
One more question. Will insurance carriers respond positively to the cost-effective analysis of the various tests and more frequently approve exome sequencing?
That's a great question. So it's really insurance carrier by insurance carrier. So there's one insurer that actually has really taken these data to heart, and they actually are often preventing us from doing tests other than whole exome sequencing. They almost mandate that we do whole exome sequencing as the genetic test for patients with that insurance carrier. For other insurance carriers, it's the exact opposite. They're just kind of honestly relying on old data about cost effectiveness, and they are preventing us from using the broadest and most cost-effective tests. So it really is dependent on the insurer. One of the things that is available for a number of large commercial labs that do genetic testing now is that you can send testing off to the lab. And I should mention, a lot of genetic testing that we do now is on a buccal swab sample as opposed to a blood sample. And that buccal swab sample is something that's very easy to obtain in the clinic. It's just a brush that you use on the side of the mouth, or just spitting into a saliva tube. And that can be mailed off to a lab without the involvement of a phlebotomist or a blood draw. The advantage of that then is that the lab can work directly with the insurer for the patient, and they can protect the provider, the pediatrics office, from the financial risk of potentially obtaining that test and having it not covered by insurance. So what those labs will do is take the sample, they'll extract the DNA from the sample. They will, after extracting the DNA and having the sample, they will try to obtain approval from the insurance company, and then the labs can work directly with the family to provide the family with the out-of-pocket cost, and the family can decide about whether to proceed with testing or not based on the out-of-pocket cost that they get from the lab. And that way, that kind of removes the pediatrician and pediatrics practice or the hospital from the equation, from having the financial responsibility to tell patients what testing costs, and also from having the liability if that testing isn't covered in terms of the cost of that testing. A lot of people ask me, using that strategy, is the buccal swab testing, is it lower quality than blood testing? And the answer is usually no, although sometimes they're not able, that CNV analysis piece, the part of exome sequencing that can now replicate chromosomal microarray, that piece actually requires a higher quality DNA sample. And so sometimes I will get, occasionally, a few percent of the time, I'll get a test result back from a buccal swab sample, and it says that they're able to do the sequence analysis piece, but they're not able to do the copy number variant analysis piece. And therefore, we might still need to get a chromosomal microarray, or just get a new sample, actually get a blood sample, and then send the blood sample for higher quality DNA. But if they do provide a result from that test, the results are just as valid. There's not much downside of using that buccal swab sample as opposed to a blood sample for genetic testing.